Hi everyone, I want to talk to you about gestational diabetes mellitus. You've heard about diabetes mellitus. I've made a full presentation on diabetes mellitus before. You can check that out. But this one is a bit different. I remember I named this as part of the different types of diabetes mellitus when I made a presentation on diabetes mellitus earlier. So let's go. Want to know more about gestational diabetes mellitus? Okay, in pregnancy, the placenta can secrete some hormones, and they are placental lactogen, growth hormone, corticotropin releasing hormone, progesterone, and prolactin. These hormones are working mainly to supply the fetus with adequate nutrients, but with insulin resistance, it turns to gestational diabetes mellitus. In other words, all these hormones are meant to be doing good job. The good job is to supply nutrient to the unborn fetus. However, because of possibility of insulin resistance, we have problem. And the problem is gestational diabetes mellitus. So it is expected that once the pregnancy is over, the placenta is pulled out of the mother, the effect of these hormones should be going down because placenta is responsible for facilitating the release of all these hormones and the effects that follow. There's a situation called pregestational diabetes. This is diagnosed with diabetes mellitus earlier than being pregnant. This type of women, they know that they have diabetes mellitus and they have been diagnosed. Some may not know anyway. They're having the symptoms, maybe not too long before they started having the symptoms, and they've not seen their physician to make determination about their status as per diabetes mellitus, and suddenly they're pregnant. However, the fact about here is that this is not pregnancy induced. This is not as a result of placenta implantation and the hormones that are released subsequently. No. This is because before this woman is even pregnant, she's been diagnosed with diabetes mellitus, or she doesn't know, but is already there in the system. So, pre-gestational, before pregnancy, they are diabetic people. They carry more risk. They have more risk than pregnancy-induced diabetes mellitus. They have positive family history, and they can have body mass index that is very high. I want to be respectful. I don't want to use the word. Okay, you understand what I'm saying? When the body mass index is high and there's possible family history, okay, let's call it obesity, okay? Hemoglobin A1C is going to be greater, okay? And they have more severe neonatal hypoglycemia because the baby is just being formed, it's growing, and it's delivered in the medium that is very high with glucose. And the baby is out right now. I have a separate presentation on neonatal hypoglycemia. You can check that out and you understand better that immediately the cord is cut off. The supply of glucose is cut off. And the good nurses are still there, dressing the baby, keeping the baby warm. When the level of the high insulin that has been battling the high glucose has not dropped so fast like the glucose has been cut off suddenly. So the hypoglycemia is there. Now compare a baby that is growing in that medium throughout, and suddenly pull out, and the supply is also cut off. So they have larger babies. Gestational diabetic mothers produce large babies, but those who have pre-gestational diabetes mellitus have larger babies. More congenital defects, more adverse neonatal outcome. Why that? Organogenesis in the first few days of intrauterine life occur in the phase of hypoglycemia. So the organs were formed right in the midst of high sugar, and that's not too good. That is the reason why they have more babies with congenital defects than gestational diabetic mothers, who in all cases of gestational diabetic mothers, before they start having the problem full-blown, organogenesis period would have passed, because we've even started testing them from gestational age of 24 to 28 weeks, and organogenesis had come and passed. The rest is development. Okay, now gestational diabetes mellitus. It is worldwide. Fair to say that it's common in blacks, Asians, and natives. It's almost the same pattern with type 2 diabetes mellitus. What are the risk factors here? Family history, or personal history of gestational diabetes mellitus, like someone who is not a primate, someone who had had babies before, and while pregnant with those babies, she had gestational diabetes mellitus. So it's not going to be surprising that now she's having it again. Previous large babies and keratosis nigricans, that is cutaneous sign of diabetes, common in type 2. It's not that you can't find it in type 1, but it's less. Older age of the pregnant woman, like if a pregnant woman is 35 and above, is closer to having it, particularly those who are susceptible to type 2 diabetes mellitus based on their lineage. Obese mother, ethnicity, like I said, blacks, Asian, natives, unhealthy diet, smoking, stoppage is very necessary, and of course, a sedentary lifestyle. These are some of those risk factors associated with type 2 diabetes mellitus as well. You can check out my presentation on diabetes. You'll get all these risk factors there, but we're going more on gestational diabetes mellitus alone now. Okay, how do we make the diagnosis of this gestational diabetes mellitus? Like I've said briefly a while ago, we'll start testing pregnant women at gestational age of 24 to 28 weeks. First thing is 50-gram glucose is given per hour. 1 hour later, we're going to take sample, and that's going to be serum. And we're going to estimate the glucose level. If the value is greater than 7.8 millimoles per liter, then we're not going to tell this woman you are fine. So we'll be suspicious that it's likely this woman will have gestational diabetes mellitus. Then oral glucose tolerance test will follow. So 7.8 millimole per liter is assumed to be positive. Then we will start the 2 hours 75-gram OGTT, or 3 hours 100-gram OGTT. OGTT is oral glucose tolerance test. Now, 75-gram oral glucose tolerance test. What I'm going to do, when we have done the 50-gram per hour, and there was a clue because the value was 7.8 millimoles per liter or greater, then we're going to sit the patient down. Okay, we are suspecting gestational diabetes mellitus in you. You will go home today and after your supper. You're going to fast for at least 8 hours and come tomorrow morning. So when the woman comes back, sample will be taken the second day before eating, and that will be like fasting blood sugar. We'll read that and record it. Then we're going to give the 75-gram oral glucose, okay? And start measuring 1 hour and 2 hours later. So when the fasting blood sugar level is 5.2 millimoles per liter, is considered positive. And when the serum glucose is measured 1 hour after giving the 75-gram glucose per oral, if the value is greater than 10.0 millimole per liter, it is positive. Or if it is 10 on the dot, is assumed positive as well. If the second hour, the 2 hour later value is equal to 8.5 millimoles per liter or greater, it is assumed to be positive. You make the diagnosis of gestational diabetes mellitus once you can have the plasma levels at above these positive values in 2 occasions. Like if the fasting blood sugar is 5.2 millimoles per liter or greater, and your 1 hour is 10 or greater, or the 2 hour is 8.5 or greater, then you can tell the woman you have gestational diabetes mellitus. On the other hand, some centers will use 100-gram oral glucose tolerance test. If your center chooses the 100-gram, then it's going to be 3 hours. 3 hours oral glucose tolerance test. Then fasting overnight for at least 8 hours before the sample is taken. That will be the advice. Then the woman presents and that the sample is taken the first thing before administering the glucose. And you've picked the value of 5.3 millimoles per liter, that is positive. 1 hour, you check the plasma. If it's 10.0 millimoles per liter or greater, that is positive. 2 hours, you check the plasma again. 8.7 millimoles per liter is positive. The third hour, if the sample comes back and the value is 7.8 millimoles per liter, it is positive. So when you check all these, you now have 4 values. If 2 of those 4 is at this high level or greater, then you can make the pronouncement that you have gestational diabetes mellitus. Okay, sorry, you are pregnant, congratulations. We've done the test. You are diabetic. You have gestational diabetes mellitus. Sorry about that. But what's the next thing? Diet control. Diet control, but you must meet the name of the mother and the growing fetus. In other words, don't say, oh, okay, I listened to one presentation on gestational diabetes mellitus, diet control. You're going to call the diet. Please be careful. The mother is feeding the effective parasite inside, okay? The fetus. The fetus is not bringing anything, it's feeding on the mother, okay? So this mother must feed well so that she and the baby inside, or sometimes babies, if there are multiple gestations. So be careful. We don't just shut the supply down like that. Exercise as it is appropriate. Glucose self-monitoring. Well, mothers, this could be difficult for you to handle, but for the safety of yourself and for good outcome, you have to, please. Insulin. When I was in medical school, insulin was the only medication to be used. And up to now, insulin is still the only med in most centers. Nowadays, some use metformin if they can't use insulin. Glyburide is also acceptable if they can't use insulin. But either the insulin or metformin or glyburide, actually metformin doesn't crash the glucose level down so fast like insulin would do, but glyburide could have profound hypoglycemia as well. Either way, either you use any of these three or not, educate this pregnant woman about hypoglycemia. Lucky enough, I made presentation on hypoglycemia already. You can check that out and you have details. So you know the symptoms from there. There's adrenergic symptoms and we have neuroglycopenic symptoms. So check out. And of course, immediate intervention going about with lifesavers, glucagon injection, and all the likes. Inform the family of the prognosis, what they're going to make at the delivery, what the baby is likely going to be, the stress that the family is going to pass through, as per diet, and so on and so forth. Consult OBGYN specialists and endocrinologists. What are the possible complications? Big babies. Why? They have a lot of glucose, and that has worked on the pancreas. Beta cells has produced lots of insulin, and insulin is an anabolic hormone. So insulin is very good in helping not only controlling the glucose, but also building every part of the body, anabolic hormone. And that's why they come down with big babies. Preeclampsia. Well, if well managed, it will not progress to eclampsia. I'm not going to say more on that. There will be a separate presentation on preeclampsia and eclampsia. Polyhydramnios, stillbirth, neonatal hypoglycemia. Please check out my presentation on that. I have that already. Congenital birth defects, particularly with gestational diabetes mellitus. I've just talked at length about that a while ago. Birth trauma, yeah, so that dystocia. And because this case will be hair will be forced out and so on and so on. Some with equipment delivery, vacuum and anything like that. So instrumental delivery, and they have trauma here and there because they are big. Cephalopelvic disproportion, that is what I meant by CPD. And that means the passenger is bigger than the passage. I don't want to mention it more than that. So the baby is bigger than where the baby will come out from. And because of that, we end up with cesarean section. There will be other investigations that will be done. The fact that this is a woman with gestational diabetes mellitus and we've been working on the glucose level doesn't mean we are going to ignore other aspects of her life. So we check the complete blood count, check if there's anemia, if there's any sign of ongoing infection, or you can even pick something surprising like malignancy. Then renal function test, what's happening to the kidney? Is the kidney working well? How about the liver? Liver function test. Any causing factor derangement? In fact, it is necessary we know. Because if somebody is having von Willebrand disease and so on and so forth, although it's not manufactured by the liver, but once there is a sign that there is clotting problem, we'll be able to rule out the rest. Diabetic foot. Now, some don't sense pain and they can become injured and they won't know about it. Ophthalmoscopy, cause of possible retinopathy, lipid profile, thyroid function test, electrolytes, urinalysis, urine microscopy, culture and sensitivity, because We want to find out if this woman is having bacteriuria. We don't want her to come down with pyelonephritis. So we do urine microscopic culture and sensitivity. In conclusion, good glycemic control will lead to good outcome in both mother and the baby. Please, to the mothers, kindly endure the hardship for the sake of yourself and the unborn baby. Thank you for listening to my presentation. Kindly subscribe and you'll be getting these publications immediately they are released.